What's up, everybody? This is Jeff Moore, currently serving as the CEO of ICE. And before we jump into today's episode, let me take a moment to introduce Jane, the clinic management software and EMR that so many of us in the ICE community use and practice. Change is a normal part of clinic life. Maybe you're expanding your team, introducing new offerings, or growing your client list. As your clinic evolves, it's important to have an EMR that not only supports those changes, but also grows with you. Jane's new Balance, Practice, and Thrive pricing plans offer flexibility, allowing you to easily switch from one plan to another depending on your current and future needs. There's no long-term commitment either, just simple month-to-month payments that let you focus on running your clinic. And with every plan, you get features like one-on-one telehealth, email appointment reminders, and unlimited support. Visit jane.app/pricing to find a plan that fits your needs, starting at $39 a month here in the US. And when you're ready to get started, use the code ICEPT1MO to sign up for a 1-month grace period on your new account. Thank you so much and enjoy the show. Christina, welcome back to the show.
Thank you so much.
Number 2, we're going to start off with our question, as always. Where is somewhere that everybody needs to visit on your side of Canada?
Ooh, that's a good question. I think everybody needs to be in British Columbia. They need to go up to Whistler. It is just ridiculous. So beautiful. It is this quaint little town. There's so much skiing, so much outdoor stuff. Yeah. It is just absolutely beautiful.
I skied there one time in my life, and it was like that epic day. 6 inches of fresh powder in great visibility, which they say is not very common there, that you can see for a long ways. Ridiculous.
So beautiful.
What about on the other side of Canada?
Newfoundland's beautiful.
Okay.
I haven't been there myself. I wish I could. It's on my bucket list, but there's so many people who talk about St. John's, Newfoundland and how beautiful it is. Everyone calls it Newfoundland. It's Newfoundland. And I've been out to Nova Scotia. Super beautiful too.
Fantastic. Let's dive right in. We're talking falls.
Yes.
We aren't talking falls prevention. Well, maybe we're talking falls prevention as one piece of a multimodal puzzle. You run our MMOA division, our older adult division here at ICE. You all have been challenging the falls narrative progressively, I think.
It's getting worse.
Maybe start where you all began to realize that what was going on in the falls space was not enough. Maybe start, where did you begin chipping away? And then we're going to take us all the way up to where we are modern day, and then where we're going from here.
Oh, yes. Love this. Okay. So when we are thinking about working with older adults, you cannot be in the geriatric space and not think about falls prevention. Totally. Our healthcare systems have spent billions of dollars. Our research space has spent billions of dollars of trying to prevent falls. And when we were developing our older adult curriculum, it became very apparent that there has to be some component of falls prevention within our curriculum because it's such an important part of working with older adults. We've all been there where we've seen an older adult who has had a fall, who, because of the injury related to that fall, has had a permanent change in their independence, or it made them have to transition from home into institutionalization, or they passed away from that fall, right? It is a reality.
Totally.
And so as we were developing our curriculum, we wanted to think about the multifactorial nature of falls. There isn't one right now in the literature protocol that works that is going to help prevent or circumvent the negative effects of falls in older adults, right? We don't have this blanket protocol. And as MMOA, an older adult, has developed our curriculum, we have really started shifting away from protocols and gone more towards frameworks, right? Because there is so much heterogeneity in our older adult population. There is so many reasons why older adults fall. An example is you can have the best balance program, but if the reason why they're falling is because of nocturia at night, it doesn't really matter because it's a low light pelvic floor kind of under fatigue type of scenario. So we're kind of already poking some holes in this and thinking, okay, well, we're not just going to do one program like Otago, or we're not going to do, this blanket of exercises, give me a sheet of exercises that we're going to work on. And we started going into the research on how older adults are falling.
Okay, before you do that, I got to back up.
You told me I could rant.
You totally can. But that was a bomb you dropped right there, because you have scoured the research at a depth that is certainly parallel, if not beyond, anybody else in this space. And you're saying that there really is not a falls prevention out there that you could rely on or double down on. That's it?
I do not believe that there is a program that as a blanket statement is going to work for everybody.
This will work evidence-based with all the variables, these unique humans.
Well, we have evidence-based programs.
Yep.
But that is not the same as saying that evidence is going to work for everybody.
Yeah.
Right? Statistically, right, if we take a person from doing nothing and give them balance exercises, their balance is going to get better.
Right.
Right? But we have put billions of dollars into trying to move the falls rates in older adults, and we really haven't moved it that much.
Budget.
But where we have come now full circle is I don't think that trying to reduce falls is actually the metric that we should be looking at.
Okay. Which, I mean, that is a shocking narrative to anybody coming out of PT school. Right. All you hear about is falls prevention.
Right. And this is Christina of 2025. I didn't say this as Christina of 2022. So let's kind of get to where we got here. Every single time we teach a course, we open up about the definition of falls. So a fall is an event where a person comes inadvertently to the ground or other lower level, right? We know the statistics.
Yep. We
ask the room, okay, who in the room has had a fall in the last year, right? And we've been doing this now for many years. Every single course that I have taught, that number has been between 40 and 70% of the people in the room have had a fall in the last year. And they're all ages, usually under the age of 65.
Yeah.
But we use the statistic, did you know that 1 in 3 older adults fall every year? Right? And so now I'm thinking, okay, I'm going to zoom out. I got littles at home, 3 and 5.
Yep.
They fall every day.
Totally.
Every day.
Literally, yeah.
And then they get a little older. Our kids get a little older. They probably fall every week. I teach undergrad courses in balance, and about 80 to 90% of them are falling every year, probably doing some sort of stupid stunt,
Sure.
being in college. And then now 40 to 70% of our people under the age of 65 are saying that they're falling. And so now I'm thinking, well, if I put that into context, falls rate is actually declining.
Interesting.
Over the age of 65. But we never really zoom that out. And that 1 in 3 older adults fall each year is the introduction of every paper.
I've heard it a million times.
Oh, in every paper in falls prevention, that's there to set the narrative of why this is important.
Totally.
And when we say that, we are doing it in a conversation that oftentimes is trying to bubble wrap our older adults. Be careful, do less, be mindful of trips and slip hazards. And what it inadvertently does is it deconditions people because it gets them to disengage with activities that normally they would do because now they have a heightened sense of needing to think about safety, and their perceived safety in a scenario may go down. So they may think that they're not as safe as they were before because now they need to be more mindful because did you know 1 in 3 older adults fall each year?
Yeah.
And then the narrative gets even scarier. Like you don't want to break a hip.
And if you do,
50-50 shot your hearing ear if you do.
Totally.
And then we use that statistic. Did you know that falls account for like 90% of hip and wrist fractures? I was like, okay, well, under the age of 65, outside of a motor vehicle accident, tell me a person who has had a fracture that has not been related to a fall.
Yeah.
That's how fractures happen, is when you fall and the tensile strength of your bone is less than the ground reaction force of your fall. Totally. And when that mismatch happens, guess what? You fracture a bone.
Yeah.
Right? And so this narrative doesn't really make sense, right? When I'm thinking about it in clinical context, yes, I get the research and we have these numbers, but when I extrapolate it out, it doesn't really fit. But what we do know is that there is an exponential increase of years living with disability when individuals have a fall over the age of 65. So we know that older adults get hurt, they don't recover from that injury, and they end up with disabilities or worse because of that fall. Because of that, what I should be trying to do as a clinician is bulletproof them, not bubble wrap them. And so what I need them to do is not to not fall. It's they need to be able to recover from that fall. They need to be able to get up from that fall. And hopefully they're able to fall well so that we can teach them to try and, if we can't increase the tensile strength of the bone, at least to a large magnitude, for example, in osteoporosis, then the other option is to bring down the ground reaction force of the fall. So I'm going to teach you how to fall to hopefully avoid your bony prominences and spread that load across bigger areas so that hopefully we're avoiding the more severe injuries. But our education is so much about safety and risk and not accepting risk that our older adults often disengage in what they consider risky behavior. And those risky behaviors, again, I'm air quoting, they're the ones that are going to promote them to be able to withstand that fall should they have it. There was a paper that came out. It was a qualitative study on masters endurance runners. They're in their 70s, and they're talking about their navigation of the healthcare system as individuals who are still very active. And the conversation of falls came up, and this was qualitative, so they were pulling out quotes from these interviews.
Yeah.
And I will never forget reading this paper. And one of the athletes was saying, you know, I don't know why my doctor keeps talking to me about falls. If I fall or trip on a route in a run, I just get back up. I just get back up. Heck yeah. Right. And so it's really powerful. And so where we are now coming into our conversations, or where our knowledge arc has changed a lot within our course curriculum, is that I don't know if prevention is exactly the aim. I think it's falls resiliency. And when I get a person and we think about preparing for a fall, we have the baseline capacity of the person to withstand forces. We have the slip or trip, which is the common reason why individuals are falling. We can kind of get on a rant to that too. And then we have the completed fall. They're on the ground. And so that's the floor transfer. Can they get back up? Yep. And the recovery from that. So when they're on the ground, can we reduce their rate of injury, risk of injury, by teaching them how to fall? And then can they get back up when they're there? And when we do that, then they start engaging in more activities, they decondition less, and they're going to have more resiliency should that fall happen. And they're not going to have as much fear of falling, which in and of itself is a risk factor for falls. And we've kind of created it for some people in some ways. Other people have had injuries as a fall. Of course, it's multifactorial,
sure.
But there's definitely an influence of medicine.
Iatrogenic issue there.
And we like to hate on medical providers, but like I had a gal who came in to see me. She was in her 70s, and like 7 years ago, and she remembers this. Her physiotherapist, when she got diagnosed with osteoporosis, said, "Oh, you're good. Just don't fall because you'll be a paraplegic." The physio said that to her. And then
the fact that she remembers it is so poignant.
And she was coming in to see me for deconditioning related issues 6 or 7 years down the road because she stopped engaging in activities that she thought she might fall because of this osteoporosis diagnosis and what that PT had told her.
Are we doing more harm than good?
Exactly.
With these narratives.
Mm-hmm.
So then kind of circling back to the intro, if we've put all this money into it and we haven't moved the needle much on falls prevention, is your stance on that side? We're doing a lot of things with older adults, strengthening wise, for a lot of great reasons, and that's going to carry over to whatever falls prevention we might be able to get. And so are you thinking, do we sort of abandon specific fall prevention strategies or time spend with these older adults and just let the other stuff carry into someone who might fall less?
No.
Okay.
I think that the outcome that we need to be looking at is not rate of falls, but injuries related to falls. And I think those are two different things.
Okay.
Right? Because if our older adult has a fall, but they're able to get back up and they don't have an injury, that is a very different scenario.
The master's athlete getting back up because he tripped on a route.
Right. And so we're kind of setting ourselves up for failure if we think that we're going to prevent everybody from falling, because the only way that we're truly going to be able to do that is to bubble wrap a person and not get them into any type of risky scenario.
Totally.
Every day you're interacting with life, there's a risk of falling.
And the more you interact with life, the more risk.
Right.
Kind of going back to the small kids and, going on in years.
Yeah, absolutely.
And we don't want reduction of life.
Yeah. So every day we make risk benefit or cost benefit decisions, right? I have 3 dogs, which is chaos. My shepherd tripped me this week or last week.
With small kids.
Kids. Oh yeah. And I had that totally epic Hollywood fall where she went right in front of me. I splat forward, but I knew how to fall because I teach it.
Yep.
And so I got these bruises on my forearms, but that was about it. So I didn't really hurt myself. But that decision, how many of our older adults with like little pets, they're walking their dog sees squirrel goes off and they fall.
Totally.
They're not going to get rid of their dog.
Yep. Yeah.
Hopefully they will get told to get rid of their dog.
Sure.
I wouldn't put it past some medical providers. to say maybe it's time to get rid of the dog. But we make those decisions all the time, and that allows our older adults can make dignified risk themselves too, right? And at some point, and this falls conversation is often a filter of when we start saying we know better. You shouldn't make this decision anymore. You should disengage from things that bring you joy, that increase the quality of your life, because this safety profile is what matters. And Atul Gawande wrote this incredible book called Being Mortal, and it changed my life. And he talks about how our older adults and what they want for the end of their life is so different from medicine. And I mean that as rehab providers too. I'm not just talking docs.
Totally.
They want to live in their home. They want to age in place. They want to still go fishing, even if they could fall into the boat, right? Like they want to do those things. And we want to reduce 30-day readmits and reduce falls risks and talk about safety profiles. And when we have this disconnect, right, we can have a lot of people who feel like aging is this set of experiences where their independence and their decision-making is subtly or very suddenly taken away from them. And I think falls in the well-meaning narrative of trying to keep our older adults safe, we have unintentionally sometimes taken some of their joy away from them.
So the question that comes up right away is, do we have anything yet on decreasing the effects of falls on, whether it's fractures, whether it's recovery? Like, is there data out there showing that there's things that we can do?
Oh yeah, absolutely. Right. Our resistance training when appropriately dosed, our balance training when specific and actually at an appropriate intensity.
We'll come back to that.
Thank you. Put that little drop right there. Hoped you picked that up. And then a lot of our other multifactorial conditions like polypharmacy, right? And what we're seeing in our polypharmacy literature is that it's not necessarily the number of drugs, but the more drugs you're on, the more likely you are to be on a drug that has a side effect profile that could influence falls. And so falls risk increasing drugs are FRIDs. So we have, wellness screens where we're checking for any interactions in medicines that could increase risk of falls. We have some evidence there. We have some evidence around nocturia. We have some evidence around, a whole bunch of different things. Falls are considered a clinical geriatric syndrome because there are so many constellations of signs and symptoms. And exercise and our role as rehabilitation providers, I really truly believe we should be front of mind. We should be trying to build the capacity of the person, because there's not a medication you're going to be able to give a person that's going to get them stronger. And there's not a medication you're going to be able to give a person that's going to get them better or more capable with slip and trip training. It has to be done in person, hopefully, and with appropriately dosed exercise intervention.
Circle back to the balance training.
Yeah. Love this. Okay. So
what's currently happening? What needs to happen?
Okay. So again, went into the research.
Yeah.
If we are going to do the appropriately dosed exercise program that we want to reduce an outcome or change an outcome, when we were thinking about exercise prescription, we're thinking about progressive overload and specificity, right? And in aerobic training and resistance training, these are easy, right? Aerobic training can be wattage, distance, whatever. In resistance training, it can be specific movement patterns that mimic the activity we're trying to get back to, and then it's load, repetitions, volume. In balance, this is a little bit more challenging, but we need to be being mindful of trying to create specificity in scenarios that are mimicking the situations that are making our older adults fall.
Seems obvious.
Which seems obvious, but hold with me here. So when we look at our evidence, right, around, so ideally we're getting a comprehensive history from the person about what happened that caused their fall. But then we're also going to look at, what are some of our trends in our data? And what we're seeing is that at all levels, community dwelling older adults, our homebound older adults, our individuals in institutionalization, our individuals in acute care, they are falling in dynamic scenarios. Most of them are walking forward. Some sort of slip, trip is happening, oftentimes in a dual tasking scenario, and it's causing them to fall. Okay. You would think that because of that would be our first go-to intervention. But it's not. It's standing in tandem by a counter, trying to not tippy our fingers on a counter and staying there for 30 seconds.
Everybody does it.
Everybody does it. Everybody, that's what I got taught.
That same.
Yeah.
Yeah.
And I was like, okay, how can we slap a static solution on a dynamic scenario? Not a single older adult that I have seen has ever said, I was standing in tandem and I fell over. And so, yes, we should be the frontline provider. But if we are not getting them into, like, you standing in tandem isn't going to stop you from being able to recover when somebody bumps you on the street. That's never going to happen. And so there's kind of this hierarchy of balance that we see where people go from the bottom with static, and then they put in dynamic, and then they put in maybe some reacting stepping, and then reactive stepping, and then some dual tasking. And what we're trying to do at older adult is flip that. Because what we see is that individuals who do static balance, it doesn't carry over to these higher level tasks, which is how our older adults are falling. But when we put in some of these balance layers and we do these dual tasks, it transfers into better static balance. So the hierarchy, when we start at the top at the highest difficulty, it trickles down to our lower levels. But when we start at our lower level, it doesn't trickle up. Does that make sense?
It totally makes sense. Mm-hmm. You can appreciate or at least sense the rehab provider response of, but hold on, I'm afraid of the person falling in the clinic. Like, I don't want to start off with something, I mean, I think there's a fear on behalf of the provider there, or rehab provider.
Yeah.
Of, hey, I feel comfortable when my older adult is doing this for sets of whatever, but I'm not feeling at all comfortable with dual tasking and them actually possibly hitting the ground and et cetera.
Come to Older Adult Live.
Come to Older Adult
We're going to help you out there.
This is the pushback.
Oh, well, we don't get pushback after the course.
No.
Because we really systematically show you we can edge into that intensity, but maintain that safety profile.
Yeah.
And when we do that, our older adults just get so much better, so much faster. And, so many of our people say, well, my client isn't compliant with their HEP. I don't have that problem, right? Because we have that specificity.
It's relevant.
Not everybody's going to do everything that they need to.
Sure.
But I haven't done a balance, like a static balance HEP program in probably 4 years.
So what does it look like? So when we throw words like dual tasking out there, some of the folks might not be tracking. What are you advocating for?
Okay, so here's the easiest way for you to 10x your balance programs. Okay. Keep the side-by-side stance. Do it by a counter and get them to manipulate an object. So bring a scarf and roll up a scarf and unroll it. Okay. Get them to move something from one side of their body to the other. And what you did there is you just layered in a motor dual task. And now the effectiveness of that intervention is significantly higher. The safety profile didn't change because they're still standing by that counter.
Yep.
You're still challenging their balance. But now they, instead of holding onto the counter, they're manipulating an object in front of them. They can still let go of that object and grab hold if they need to. But you've added in that dual task. And it's created more of a similar scenario of like they're navigating around their kitchen and all of a sudden they trip on something that's on the floor, or like their rug that you're never going to get them to remove.
Give us other examples, things that are higher level. So once you're a little more confident with someone, what kind of dual tasking might that look like?
Yeah, so it truly does depend on what their mechanism is for falling. Okay, so here's an example. We have an older adult who falls at night. Okay, put sunglasses on them.
Nice.
And do all your interventions with sunglasses on, because we can't mimic the scenario of a loss of visual input, right? Because that loss of visual input is important to how they're falling, right? They're falling at night, so you can assume that they're probably pretty tired and groggy. Get them to do a high intensity interval, aerobically tire them out,
get them tired,
and then get them to do their balance intervention. So it's not going to be perfect because it's not the same scenario, but you're getting a little bit more specificity of they're under a grogginess or not at full strength when they're going into that balance intervention, right? So those are easy things. And then you just pull them into like a workout. So like they do some sort of like high knees, 30 seconds of high knee stepping. They're a little bit tired. Throw sunglasses on them and get them to navigate around the clinic like they would be going from their bedroom to their bathroom. Done.
Looking at falls prevention, we've been afraid of these patients.
Oh, yeah.
because of that, we're doing training that is in no way resembling the actual problem,
No.
which we wouldn't do anywhere else if we
No.
weren't afraid.
Yeah.
We need to remodel that because what we've
Well,
done hasn't moved the needle.
Yeah, and sometimes our outcome measures have like done us a disservice, right? Because we use like our static balance test, and we're like, well, they have a deficit, so I'm gonna cater to the test.
Easy to justify that.
Yeah, it's totally easy to justify that. Well, they have an issue with their static balance, and so I, in my goals, am saying that they need to improve their static balance, and then I'm gonna work on their static balance.
I love it. So the falls prevention space, you're not saying that you shouldn't spend time there.
No.
You're saying that we should spend quality time there.
Better
Put
time
them
there.
in environments that actually put them in this space where their unique history suggested they had an issue, and load it, progressively challenge them.
Totally.
Get them doing multiple tasks, put them in that speed wobble, get them challenged sufficiently.
Yes.
What you do a lot in MMOA, our ICE older adult curriculum, that a lot of people, I get a lot of messages for, like, what are you guys doing out there? Because you've got people literally falling.
Yeah.
Now this, nobody talked about in school.
No.
How did you all decide you were going to tackle this? And is there any research suggesting there's a best way to fall? Or is there, talk about this space of actual fall training.
Yeah.
You've spoken to prevention.
Yep.
But we know it's going to happen, and we don't want to take away their dignity and say they shouldn't do things where it might happen.
1000%.
So it's going to happen. How do we have it happen best?
Yeah, so this was definitely Dustin's brainchild. Okay, so I cannot take credit for this. This is all him. The background of this came from, there was a person, he was in his 90s, and he was going to parkour gyms, and he was teaching older adults how to fall.
Crazy.
Like, imagine the crash pads are out, and he's like, alley-oop, and like, he's just falling, and he's teaching these seniors how to do this.
Awesome.
And so what we do acknowledge in the course is that this is a very early stage of where we're at from an evidence base.
Okay.
We can acknowledge that.
Yeah.
And then so from there was a pilot study that got done that was very savage. It took older adults, very healthy, no risk for fractures.
Okay.
They tied them up to a tether, put force plates on their head and their hip, and let go of the tether. And they looked at how much ground reaction force was going through the head and the hip.
Okay.
Right?
All right.
Okay. So rough.
Rough.
And then they took half of those groups and they taught them how to fall and repeated it. And what they saw was a really significant reduction in ground reaction force through the head and the hip. And so what that was trying to show was, hey, with this training, we could potentially miss that critical threshold of hitting a concussion or a TBI because we showed such a reduction with a short training intervention on that ground reaction force through the head by teaching them to like duck the chin or in a forward fall, turn the head to avoid that orbital fracture. Where we don't know, and what we don't know yet, is when people are falling, there's a certain amount of automaticity, right? Like most people are not thinking about their biomechanics like they would for a squat when they're falling. Like
for sure.
It happens really quickly.
Yep.
And so what we don't know is like what that dosage looks like to turn into an automatic response to falling. Right? We see those people that did, gymnastics or cheerleading or Krav Maga or some sort of jiu-jitsu. Like that does become very automatic because they are falling all the time.
Reps. Yeah.
They're getting reps. So we don't really have a dose response curve for that. But we do think that, in our coursework, we do impact, which is trying to increase the tensile strength of the bone. And then the other side of that equation is trying to reduce the ground reaction force of the fall to try and prevent that fracture. And we think that's going to be something that's going to be very... it's going to have a lot of positive change potentially for falls risk. So we're hoping that there's going to be a bigger building of evidence in that space. Where we have now gone then is starting from lower ranges of motion, so lower segments, and then building to higher segments to teach forward and backward falling. And it's so funny when you see the clinicians, because at first, when you see us as faculty, and we're so confident and comfortable falling now because we teach it all the time.
Yep.
And you see the look in the clinician's eyes.
It is a sight to behold.
Yes.
Yeah.
And then we break it down.
Yeah.
And then we show that we can also facilitate and offload weight for people who are really trying to work on their mechanics. And by the end, people are like responding with cognitive tasks and they're leaning forward and then they're just letting go of tethers and down they're going. Yeah. And it's within session, there's such a huge change in our clinicians' confidence. And it's really cool to see. And so I had a client scenario, which was super fascinating to see this kind of come full circle. obviously I talk about this a lot on social media, but I had a client, she had a bilateral hip replacement, and her doctor told her that she couldn't ski anymore. Already, I'm like very against that. So she comes to see me. She's built a lot of strength. Like she's deadlifting in the 100 plus. She's in her late 50s now. And she starts seeing my content online. And she goes, do you think I can ski again? And I said, heck yeah, I do. Like, you have so much strength. You're now, several years post-op. And then she saw our fall stuff and she goes, can you teach me how to fall so that if I did fall when I'm on the ski slopes, that I would feel okay about it? So she kind of built up her strength. She comes into the clinic. We go through forward, backward, and sideways falling. And she told me this story that because she'd kind of done all this work, her family used to go on a big family reunion trip skiing, and they hadn't gone in years, 5 or 6 years. And because of all of this, she was doing this big family reunion, and they were all going skiing together, and they were all going to be there to watch her get back on the ski slopes after so many years, and thinking that it was something that she was going to have to say, that she was going to have to say goodbye to. She's like, I'm just going to go on the bunny hills and the greens, but I am you have no idea how excited I am. And that was just such a powerful moment. You just have those patients that stick with you. This was 18 months ago. And I just think about this story all the time about how life-changing that was for her and her family.
For sure.
And it was just such a powerful moment. And it kind of brought in the falls and feeling confident, not only that she isn't going to cause irreparable harm by going skiing, but that she's also thought about her quote unquote worst case scenario, which is if she did fall. Mm-hmm. And now she feels confident that she can fall there, which, fear of falling is its own independent risk factor. So if we can build that person's balanced confidence and then know that in the event of a fall, I also know how to fall and I can get back up, because we obviously went through that too. Don't push a person over until you know they can get back up. That it was just such a powerful moment.
Yeah. Let's talk about that last part, because now we've talked about when someone does have risk factors or some fear or what have you, there are ways to go about in a more logical fashion falls prevention. You can train the actual art of falling, right? It's been out there. There's a crazy study apparently where people are letting go of leashes, and that's awesome. And then once they're down, you can build their confidence in getting back up. And this is covered in the coursework as well. How, I guess, speak to that space, because again, not something often talked about.
Yeah.
Where did you learn the strategies best? Talk about that part of our curriculum.
Most of our course content is mistakes that we have made, trialing and error with a lot of things, and learning from that and trying to prevent other people from making our mistakes.
Yeah.
When it comes to getting a person up off the floor, so many of our older adults, they're so different, right? Someone's going to have a rotator cuff issue. Someone's going to have a restriction here. Someone's going to have, maybe they're going to have a knee. Maybe they're going to have a knee replacement. Maybe they're going to have an amputation. Maybe they've had a stroke. It's so hard to say, just so many things, right? Frameworks over protocols.
Like best practice, or it'd be impossible.
Yeah, it's impossible.
Yeah.
And so we always start our lab on floor transfers saying, I don't need this to be pretty. I need them to be able to do it, right? I'm not looking for, because the people that need to learn this are the ones that are at more vulnerable states from a MSK reserve perspective. They've either got high pain or low strength reserve. The firefighters know their name. Hi, Mrs. Robinson. Nice to see ya. Right. And those are also the people that we tend to avoid doing these types of interventions with, even though they need it the most, because we're afraid of the outcome. And
so true.
So we go through and we give lots of different options, and we get them to brainstorm through, and we say this isn't the perfect, everyone's going to use this. And then we go through scenarios of okay, take this arm away because they have a rotator cuff issue. This person's got complete hemiparesis, and so they can't use it. They're in synergy, so they're in flexion and extension. So you can leverage that. And we just kind of make up different scenarios, and we say, if you're going into a scenario, role play it. Try and figure out,
And for those listening, you literally have these clinicians doing this. I mean, they've got a hand behind their back.
They're tucking their arm into their shirt so that's not there. And it doesn't look pretty. It looks kind of messy, and that's fine, because we just have to make it work with our older adults. And then we also do a lot of brainstorming, saying, okay, what muscle groups are you using a lot because you have to compensate? And if floor transfers is something that you want to get to, then maybe we have to do 4 or 6 weeks of dip training, because the only way that I'm going to get them, I'm not going to be able to get them to push through their shoulders. I'm going to have to get them to anchor their upper back and push through their feet, kind of like beach style, and shimmy their body up. But they're going to need some dip strength. So we're going to have to work on triceps. Or I have a client who was told they should never kneel again on their knee replacement, and now it's pretty sensitive to weight bear on their knee. So I'm going to have to start day 1 on just weight shifting and scar desensitization to get them kneeling, so that at week 6, I can start getting them up and off the floor. So we also try and reverse engineer, saying, this is also like a very big goal. And for some people, we got to put some foundation steps in first. But if you're only thinking about it at week 6, you've missed the window.
That's a fascinating piece of conversation. Like the idea of fall recovery being that individualized, but that's the reality of it.
Oh yeah.
So, I mean, getting someone down and looking at what are their unique limitations that would prevent them from being able to safely get back up, and then literally building a strength and conditioning program. You wouldn't think of it this way, but that's what it is.
Absolutely.
For fall recovery for that individual human.
Mm-hmm. And it oftentimes augments with other things that you're doing.
Sure.
Right? But if I'm working with somebody with a lower extremity injury, oftentimes maybe I'm not thinking about doing tricep strengthening, but I should.
Right.
Because part of that lower extremity recovery is being able to get up and off the floor.
Should it happen?
Mm-hmm. Mm-hmm.
This is going to be tough stuff to study.
Yeah.
I'm just trying to think of your research brain. Like the fall efficacy, falling well, and the recovery from it, just because the individual variables are, I mean, heterogeneity is always a problem, but this is taking that to like a whole nother space.
Yeah. I've talked to a lot of geriatric researchers about this.
Yeah.
Because we see this as a big problem in geriatric practice and geriatric research in general. Because if it has to apply to everybody, it tends to apply to the person with the lowest level of fitness. And we see that translate into our programs, right? Otago, we see it in Silver Sneakers, right? It's often in the communities, but would do better in an assisted living facility because it tends to cater to those with lower levels of function. And so I've talked to a lot of researchers saying, how do we be pragmatic about scaling up? We always focus on scaling down.
That's interesting.
And so we create these blanket guidelines that create conservative, like pretty conservative
for sure
exercise
lowest
guidelines.
Common denominator stuff.
Yep. Right. Because we have to apply it to everybody. It's why I'm very anti post-op protocol. I think they're dumb. And
casual.
Just casual. That's such strong language,
Circle
but
back.
I kind of do. But it's because, right, the 90-year-old recovering from the rotator cuff repair is getting the same post-op protocol as the 45-year-old. It's the same timeline. After the 16, 20 weeks, right, they're going to start deviating, but that's a critical window.
That prescriptive part is so critical.
It's so critical. And we don't ever get allowed space to deviate based on the fact that we're trying to reduce strain on a graft or trying to reduce strain on a human, but strain is a direct measure of fitness. And so where I've kind of thought about from a research perspective is how do we be a little bit more pragmatic about this? Like we have our base.
Yep.
This is our base program. But how do we build this up or deviate this to meet the demand of the person that's in front of us?
Scaling it up.
And then the other thing that we have to do potentially, which is harder, is that we have to cinch in or make our eligibility criteria a lot stricter. And that has its own unique challenges, right? Because then if we're thinking the heterogeneity of falls prevention, and then we have to get this arm of individuals whose falls prevention risk is because of this one variable, then recruiting that is difficult. Translating that into practice is difficult, and because we want generalizability into clinical practice. And so it's a unique challenge, but I think we have ways that we can go about it. We just have to, think about it a little bit more. And I think that's where our clinician scientists have a very unique role, because the only reason why I've been thinking about this is because I've been in practice for 10 years and I'm critically in the research space. So I'm thinking, I'm not trying to prevent a fall. I'm not trying to stop falls. I just don't want them to get hurt if they do fall. So then I'm looking at these RCTs and thinking, well, falls rate isn't what I'm looking for. And so again, we start getting into these conversations where now how do we think about this a little bit differently?
What's sort of cool about, I mean, on one hand, it's a little bit discouraging thinking about, could this be looked at in a way that is scientifically valid, that would have good external validity? But on the other hand, what a cool world of creativity for the individual clinician.
Yes.
Like for this human, how
Yes.
much good can I do them?
And we really do try and put that forward in the coursework, right?
Yeah.
Like so many clinicians come to us and they say, I need you to tell me what to do.
Totally.
I need you to give me the case study that tells me how to do this. Like give me the play by play.
Yep.
And that's not the way this works,
No.
right? So we give the framework where we say, okay, here's the mechanism that we're seeing in the research. You're going to take these mechanisms, add your client's subjective story taking, like their storytelling story. They're going to tell you how they fell. Sometimes they're not a great historian. Sometimes they are. Now, in our literature, we have this list of intrinsic and extrinsic risk factors that seems to incur a higher risk for falling in the next 12 months, right? And so we have this list. Now, this is giving us this clinical picture. Now we need to apply outcome measures that are going to show us what this looks like, right? So we need the right outcome measure because we don't want it to have a floor effect or a ceiling effect. Yep. And the Berg balance isn't going to work for my community dwelling older adults when the first thing I ask them is, can you stand on one leg?
Yeah.
Right? I don't need them to sit for 2 minutes unsupported. That's a waste of their time. It's a waste of my time.
Totally.
So we want to give you options. And then from there, I don't like doing outcome measures just to do them. I want you to do an outcome measure so you get the next step. And I'll tell my students too, I'm like, I don't need you to know all the steps. I need you to know the next one. And with that, it gives you a lot of freedom. And we say that to our clinicians, not you all could have the same patient and your intervention could look a little bit different and none of them are wrong. As long as you've created this triage list, you've gone along this framework and now you have your next step. And then the variable that matters for everything, not just falls prevention, is effort. And it has to be effortful. Yeah. And that's true in aerobic training, resistance training, balance training. And that is a pivotal variable that is missing in almost all of our geriatric exercise programs, irrespective of the reason why they're coming in.
Mm-hmm. In clinic, have you had clinicians struggle with reimbursement for some of these strategies that we're using? Or is this relevant enough that who's going to challenge? Surely this is needed.
I'm Canadian. I don't have insurance. Doesn't dictate that for me.
But you're in the States teaching to 30 people all the time.
Never.
You just were yesterday.
Our other faculty have never had an issue.
Yeah. Yeah.
This has never been an
Working
issue.
on falls is not going to get a whole lot of pushback.
No. And that's where this framework actually works better because you're going to use the outcome measures that are going to show the deficits that our clients have, especially some of our higher level clients, right? Where they're not going to hit a clinically relevant threshold on the Berg. And so they may not get insurance reimbursement if you're not using the right outcome measure because you're not showing the deficit.
But that's your own damn fault.
Right.
Yeah.
Right. And so that's where, even with our outcome measure selection, we go through some that we really like in the strength space, the aerobic space, the balance space, and general mobility in the course. But we also acknowledge that one of the very cool things for my nerdy brain is that our outcome measure psychometrics, reliability, validity, and external construct is very strong. And so we have lots of different options. And I think that's a good thing, not a bad thing.
Man, the spot you really got my wheels turning in the best way, because my brain is still kind of stuck in what I learned, which was an old school way, I think, as you all are progressing things. But it's like, all your resistance training with older adult research, I wonder if you could track that and see if it decreases falls. But then there's my mind again going in the wrong direction.
Yeah.
Dude, you don't want to decrease. You don't want them doing things that result in less falls. You want more life.
I would argue already that just by being 65, they fall less than my 40-year-olds do. Have you had a fall in the last year?
Yes.
Yeah. How'd you fall?
Skiing last week with my son.
Okay. See, there you
Hard.
go.
Yeah.
Did
These
you
18-year-olds go, I didn't foosh. Although there was a lot happening, Christina. There were things were flying. I can't recollect it.
Skis are up.
Oh, so much action. I fall all the time, now that you mention that.
Yeah, exactly. That's what I mean.
I know it might be a little bit off topic, but because you just dropped it out there and now the audience is wondering, this conversation about post-operative protocols, we're talking about older adults. They have so many total knees. They have so many. And you've made a few posts lately that have gotten a lot of attention, especially around. Can you just speak a little bit? I know I don't want to get us all the way away from falls, but let's chat about it.
Yeah. So, some of our post-op protocols are actually a unique risk or issue for falls, right? Because we have our clients who get placed on weightlifting restrictions and they never get discharged from them, right? So inherently, they're actually increasing their falls risk because they're deconditioning their humans.
Interesting.
When we are thinking about post-op protocols, it's interesting because I've had a lot of opportunity to talk with docs in different spaces. And I'll never forget, I was talking to a colorectal surgeon about pelvic surgeon recommendations. After pelvic surgery, there is some weightlifting restrictions. And there is a surgical group in Australia that literally says, like, you should never do a crunch ever in your entire life. And don't let those fitness providers tell you that you should be able to do these things because you paid a lot of money for this surgery and you don't want to ruin it. That's literally their messaging.
So intense.
So intense. Like, the messaging is so strong.
Man.
And so I asked the colorectal surgeon, I said, where did this come from? And the answer that she gave me, and I was actually very pleased that she did, was, I have no idea. And when we look at some of our research that is asking our surgeons, how long are you doing these restrictions for? Can they return to this? Can they return to that? What we see is a huge amount of variability, which means that they kind of don't know either. They're kind of going with what they've seen, or I've had doctors say, well, this is what my attending told me, and so this is what I've done. And so I think the first thing that we need to acknowledge is that a lot of our docs are not, and even acknowledge that they are not using evidence-informed post-op protocols. Yeah. In this space of post-op hip protocols, what we're seeing is that we have systematic reviews back to 2015.
A decade ago.
Yeah. Systematic reviews, which means it's not even the primary data. It's a summation of the evidence saying that post-op hip precautions actually do not reduce risk of dislocations and increased risk of kinesiophobia, fear of movement. We have now multiple systematic reviews from that 2015 one that have said all the same thing. Our risk factors, and this is where I get sassy, right? Our risk factors for dislocation are often on the surgical management side. It's the approach to their surgery and the fit of the prosthetic. Yeah. And so in order to prevent getting, dinged about that, instead of changing your surgical approach to one that reduces the risk, it gets kind of passed down the line, and we get these post-op protocols.
Be real careful once you're out of here.
Yeah, right?
Yeah.
And that just fills me with rage, right? Because that isn't fair for my client.
Limiting life.
Yeah, it's not, and then it's not fair for me as a client who's trying to work with them, who's now trying to get them to engage in more things and tell them that it's okay. Right. And so nothing grinds my gears more than like going against the evidence. Like, I'm a researcher, like, geez. And so that kind of got my wheels turning about this. And then when we look in the pelvic space, one of the interesting things is that we have multiple RCTs now that look at liberal return to activity. What they mean by that is we're going to respect early wound healing, right? Don't put anything into the vagina for 6 weeks. You just had a mid-urethral sling.
Yep.
They took a group and they got them to do liberal restrictions. So here are your buoys. If you're feeling this, this, and this, it means that your body's tired. You need to rest. But gradually return to exercise within tolerance, being mindful of these things.
These buoys, okay.
Versus a more restrictive group that says, don't do this, don't do this, don't do this for X weeks. Yep. And what they showed was not only in that liberal group was there no increased risk of adverse events, there was lower post-operative pelvic floor burden, so incontinence and heaviness, and they had better quality of life and satisfaction with their surgery. And so I'm like, okay, I can frameworks over protocols, right? Give me the buoys. And then my third thing, which really makes me sassy, is that we are having our surgeons set our post-operative protocols and they have never actually rehabbed a shoulder. They've never done a rehab for a shoulder surgery. Yeah. I would never go to you and say, hey, surgeon, you should use this suture, not this suture.
Yeah.
Right? And I want to respectfully challenge our surgical colleagues and say, hey, I need you to respect my expertise too, right? I've seen this now 60 to 80 times or 150 times, like depending on how often you're seeing these individuals post-op. And so I want you, don't worry about the post-op stuff. Take that off your plate. Yeah. I got it.
Do your thing.
Do your thing.
Yeah.
And trust me to do my thing. And I need you to trust me, just like I'm trusting you to do the surgery, right? Yep. And that is, I truly believe, how we are going to change the burden on our healthcare system with our aging demographic.
Oh, interesting.
It is impossible for us to keep using our physicians as gatekeepers. we need to
Not
let
enough of them.
No, there's not enough.
No.
Like I where I want to change this conversation is like, I don't want to be adversarial. I want to lock shields with you because you do not have the space. You do not have the time to truly educate on this protocol, and you giving a paper packet of 15 pages of exercises ain't it. It ain't it.
No.
And so
in the same 15 pages to everybody.
Right. And the thing for me, did a PhD for fun, but I can pull that PhD around.
Yeah.
And so I have done a lot where I am pulling the PhD card.
Yeah.
Unfortunately. But I think I don't love that. I love that it's allowing me to kind of have these audiences and go into these multidisciplinary conferences. But I don't love that I see so many clinicians when I'm teaching the older adult course that are saying, my docs won't listen to me. Mm-hmm. And I hate that.
Yeah.
And I think we need to try and figure out a way for us to lock shields, because I say all the time especially when I'm having a conversation that's kind of tension filled with a doc, we are on the same team.
Totally.
I am not trying to make your surgical outcome worse.
Yeah, right.
Like, why are you,
I want you to win.
Yeah.
Yes.
Nod to in public and then talk to me in private.
Totally.
And we'll come together.
Yeah.
Like, there's so many clinicians have had these encounters rather, where because the surgeon says, or gives a funny look, now they're having this huge barrier, and they were right. Right. And so it's just why I'm pushing so hard about this is, one, we have this aging demographic. There's a lot of wait lists, even in the US. We definitely have it in Canada. Yeah. Our docs don't have time. We have the expertise. And when I have respectfully removed the post-op guideline, and I haven't really followed it, and I just, respect their symptoms and work through that, my clients are also getting better faster, right? Like, I shouldn't maybe admit this on a podcast, but like, I've had some clients where I'm like, okay, here's what I need you to tell your surgeon. Don't tell them the true extent of how much I am doing with you in rehab.
Yeah.
You are still 12 weeks post total labral repair.
Yeah.
But
yeah.
Give them a little bit. And, I had a guy once, he was a ex-professional baseball player. This is in geriatric space. He was in his 20s. And his doc said to him, he got his surgery done in February. And he's like, maybe by August, with good rehab, you'll get back on the golf course. Loved golfing. I got him back there by April. Yeah. And he was doing like assault bike sprints, because I was able to get him in, like, as soon as he got to 90, I was getting him through forward. Mm-hmm. And he had a lot of muscular reserve. His tissues were super healthy.
But that's the whole point.
Yeah.
Right? Framework's not protocol.
Yeah,
so
that's exactly.
The way he presented.
Yes.
Yeah.
And so he goes for his 12-week appointment, and his doctor goes, let me see your range of motion. He goes, and his arm flies up overhead. And he goes, wow, like, you're really far ahead. And he goes, yep, I'm just following what you told me.
Just coloring in the lines. Are you comfortable saying there shouldn't be hip precautions at this point? I mean, systematic review is 10 years old.
Oh, yeah.
We're simply waiting forever again for evidence to trickle towards practice.
Yeah, and especially early post-op, I don't know many clients who are just willy-nilly just moving their hip around. Yeah, because it's sore.
Totally.
Right? And so here's an interesting part. So somebody came back at me about that, which is fine. Let's have a conversation. And they go, you say that until you have that one person who has a hip dislocate when they're squatting low, when they go against it. That's a saliency effect.
Totally.
I am not changing my entire practice from one person.
In fact, we intentionally don't change our...
That's actually a super dangerous thing that we're seeing medical misinformation spread like wildfire because people do that. Please do not fall into that trap.
Yeah.
Like, I totally understand how a negative outcome has a saliency effect in your brain, right? You've gotten hurt deadlifting. You don't want to deadlift, right? Yeah. You have to do this graded exposure to reduce that fear, because our body is primed for negative outcomes. But the data summates all of that. It could have just been a fluke chance, and they would have dislocated standing up anyway because of whatever scenarios were coming around that hip joint, right? So when we're thinking about evidence-informed practice, yes, our clinical experience matters, but we also have to zoom that out from the standard evidence base.
Yep.
And I am not changing my stance based on one negative outcome.
Totally.
And it's so easy for that to happen in practice.
It's emotional. Yeah.
Oh, because it's emotional because you're like, oh my gosh, I just watched you dislocate.
I can never let this happen again.
Yes.
Yep.
Yes. And you're not going to get into practice for 5-10 years and not have one of those scenarios where you're like, I really wish that didn't happen.
Yep.
But that doesn't make you a bad provider.
Totally.
And you're going to learn from it and maybe see some of the outside variables that could have been manipulated. But we're not going to change everything because of that one outcome.
And I think a comfort level with that needs to be established in each clinician, because both of the conversations we've now had have the same core problem, well-meaning fear.
Oh, for sure.
Resulting in significant life restrictions.
Yes. One of the things we say at Older Adult is when helping hurts.
Yes.
Like, it's intentional to help. And where we reframe this in our exercise lectures is we think about the harm of musculoskeletal pain, but we don't think about the harm of deconditioning. And if we're not doing appropriate progressive overload, then they're deconditioning. And we actually use one of your quotes talking about how we're never going to get a person from sickness to fitness without bumping into musculoskeletal pain.
Yeah.
And so I'll say to people all the time, including my patients, I say, you're not going to expect to age without talking to your doctor. You shouldn't expect to age without talking to me, right? If you're living your life, things are going to get cranky. Okay. I'm your mechanic. I'll just tune you up. Okay. And in Canada, we're unlimited direct access. And I know this is state by state in the US, but what that's created is a lot of my older adults see me first. And they say to me, you'll tell me if I need to go for imaging. You'll tell me if I need to go back to my doc.
Yeah.
And it's been great because it allows the messaging to be very empowerment forward. And some of my older adults do really great.
And again, the burden on that provider is reduced, which has to happen at some point.
Yes. Yeah. We can hold on for dear life for as long as we want, but
we're not holding very well.
No, it's awful. COVID was our first stress test and we failed so miserably. And so I think too, like the way that we're advocating, sometimes, as physios or others in the rehab space, we can get really mad at our medical colleagues. And we're not actually going to create change if we're just coming at them. They're going to get defensive. And I think one, talking about this is like, let me help you. And two is, gently advocating for our skill set is important. Totally. And it's not always going to go well. Of course, I've been hard-walled by clients before.
We're not trying to go undefeated.
No. I remember I was at a multidisciplinary conference and I was talking about frailty and urinary incontinence, like my two things.
Yeah.
And there was a med student who was talking about how urinary incontinence and frailty were linked. And it showed that the frailty measure that focuses on physical function had a high link to urinary incontinence, and the frailty measure that looked at medical history and the amount of multimorbidity a person had wasn't linked. And I came up and I asked and I said, well, do you think that some of this could be functional incontinence, that they just don't have the muscular reserve to get to the bathroom or something around their muscular strength, because that's the frailty measure that popped positive? How can you be sure that this is like overactive bladder or urinary incontinence? And I had a urologist literally stand up, cut me off and say, because I did the evaluations, that's why. And this was in a room, like Jeff, this was a room of like 300 people.
Yeah.
And I was like, well, I don't think this is going to be a productive conversation.
It's not starting off
and,
right.
And afterwards, everybody came up to me, was like, that was brutal. But it made, unfortunately, it wasn't a good look on him. No. It really wasn't something on me. But it's, I put myself out there and that was like a public shaming, stones thrown.
You start challenging, challenging period. And those with fragile egos, there's going to be reactions that are tough.
But you know what? There were other people in that room that were listening who were thinking about it and like, maybe it is
something to consider.
Mm-hmm.
Frameworks, not protocols.
Mm-hmm. Bulletproofing, not bubble wrapping. Love that.
Resiliency training, not prevention.
False resiliency.
And again, not that we're ignoring prevention, but the prevention's individualized, specific, and dosed appropriately. Mm-hmm. And we're working on how to actually fall because we're accepting the inevitability and we don't want them to stop doing things that might lead to it. And we're helping them get up so the confidence is restored again, so we're not losing life.
Yeah, and it's okay for people to accept that they are going to take that trip to Europe where they're going to be on cobblestone roads and they could fall. That's fine.
Take the trip.
Take the trip.
Oh, I love it. I love it. It's been, I think, one of the things in the older adult division you all have done that has certainly created the most questions. Even just saying to clinics you have to have crash pads available. They're like, what are you talking? We're working with old people. Why are we falling? You know, even that. But you certainly are pushing against a long hit, which you seem to like to do.
I love doing that. I was like, let's just think about it. Let's like put our critical thinking hats on. And does this make sense?
This is episode 2. We still have not unpacked the clinical scientist. We're going to have a third coming soon, folks. Keep tracking it. Christina, thank you so much.
No problem.